The Lord Bishop of Newcastle.
Thank you, and good morning to members of the panel, and thank you for appearing before us today. Lord Chair, if there is time, I've got a couple of lines of inquiry I'd like to pursue. The first of these is on the theme of institutional opt-out. Dr. Sarah Cox gave evidence in the Commons which highlighted the staffing challenges in palliative care settings and said that 43% of palliative care staff said that if assisted dying was provided in their organisation, they would leave. We heard today, of course, from the National Audit Office report into the challenges facing hospices. So my question initially for Dr. Kite, and then I'd appreciate Fraser Rickettson's view. Could you tell us more about why it is that so many staff would feel the need to leave if assisted dying is introduced? And what are your concerns about assisted dying taking place in hospice and palliative care settings?
Thank you very much. Hospices are small organisations, and even if they were allowed, which we requested, that all organisations be able to opt out of providing assisted dying services, particularly since some of them have statutes which prevent them from doing so. But within a smaller organisation, it is much more difficult to ensure the safety of all of your staff to have genuine choice in not being able to opt in. There'd also be concern about the impact of providing assisted dying in a setting that already creates some fear amongst the communities. When you work in palliative care, you're aware of people reacting to you, slightly recoiling, because we're uncomfortable as a society, aren't we, in talking about death and dying. There's already perception that hospices are where you go to die, and I work in a hospital setting. I have to reassure people that hospices are there to improve their symptom management and general support, and that they will go home from there as often as not. So that would also be the environment in which people were working. And then I think we do see in healthcare that when there are big changes, and if people don't feel that they're able, through service pressures, workforce pressures, or a change in the ask, to deliver the kind of care they wish without undue moral distress, then they do move. I don't know if it'll be 43%, but we always see with big changes that people do move. We saw this at the end of the COVID-19 pandemic in lots of different, particularly specialist areas in the NHS. It's what happens when change happens. Unfortunately, final comment, is we do need to ensure that there are senior doctors in hospices because they are vital to the provision of specialist level care. So there is that threat.
So the adult social care sector for residential services, there are over 15,000 registered homes, and each one is diverse in how it's operated on the basis of what the care is provided. There are a number of small services and also faith-based care. We're also of a sector that relies heavily on international recruitment, where they may have different values or beliefs on end-of-life care. So it's incredibly difficult for some services to be able to implement this bill, and in our survey that we conducted earlier on in the year, some expressed very clearly that this goes against their ethos as a care service, but also goes against what they believe in. So we believe that an opt-out option is essential to make sure that these services can still deliver the care. But what needs to be combined with that is a referral process with ICBs, local authorities, NHS trusts, to ensure that the individual who is looking to receive end-of-life care can still receive the care that they are lawfully able to do so, but in services that will able to accommodate this change in need for them.
Thank you. Lord Chair, do I have time for...
Yes.
Well,
and can I say to all members of the committee, the Bishop has been very helpful in identifying which of our large panel she's addressing her questions to, and it would be helpful if members of the committee to do the same. And also to our witnesses, try to keep fairly short, because we've got a lot of ground to cover. I'm not criticising anybody, it's just a general warning. Yes, on you go.
Thank you. For Professor Sleeman and Professor Ahmed Zai, we know that access to palliative care and understanding of what it is quite unequal, and the charitable fundraising, of course, of many hospices, inequalities are often exacerbated, since wealthy areas are more able to fund their local hospices than deprived areas. So do you have any concerns that inequalities will be worsened through the passage of this bill?
So if I could start, we know that at the moment there's a huge gap between the number of people who need palliative care and the number of people who actually receive it. Potentially around 100,000 people die every year across the UK needing palliative care but not receiving it. But we also know that palliative care is not distributed equally. So you are more likely to receive high quality palliative care if you're white, if you're rich, if you have certain diseases like cancer, if you live in certain areas. What is more, some of those inequalities are actually getting bigger over time. We also are aware from studies that we've done, studies that other people have done, that public understanding of what assisted dying is and what palliative care is poor. So, for example, we did a study last year that showed that 1 in 5 people from minoritized ethnic groups think palliative care means giving people drugs in order to end their lives. It sounds shocking, but I witness that. I see that all the time in clinical practice. In clinical practice, we work very hard to build trust with patients, particularly patients from some minoritized groups. And I think there is a real worry that this bill will make that much harder. Not impossible, but much, much harder, because some groups already don't trust us. And I think, we already explain to patients, not infrequently, that we're not allowed to hasten their death. That's not legal. So obviously if this bill comes in, that may make that conversation much more difficult.
Thank you. If I could just respond to the issue of inequalities and how that prevents access to palliative care. And of course, there are two types. There's the inequalities within the populations themselves, or subgroups of the population, marginalised groups, some ethnic minorities, etc. And of course, excellent work has been done within palliative care to research and try and break through those barriers in those groups. There's the other bunch of inequalities, and that's the ones that come from the profession, in where they're based, often excluded from sort of mainstream, separated from mainstream healthcare in independent hospices, and also the fact that we wait until patients come to us, and usually that's very late. I think the last figure I've got is, the average time from referral to palliative care to death is about 6 weeks. That's pretty late. Now, 15 years ago, we started working in Sheffield on a screening tool to try and improve access. This was funded by the Sainsbury's Foundation, and we developed a screening tool called Spark. It's used around the world. It's hardly used in the UK, and the point is, it's a way of independently asking patients to state what their needs are. Now, we don't need to wait until they're dying. We can actually identify those needs much earlier. And I think this is the problem. It's not just a problem with the populations, it's our approach. How are we reaching out to them?
Thank
you very much.